All right, I have straight up 9 o'clock, and I think we have a interesting topic today, to say the least, one that we get a lot of calls about on billing. So we're going to be able to learn more about that. So thank you for joining our ECHO. It's June 9th for those of you keeping track. I'm getting a little better with that, it seems. I do have a woodpecker outside my window, so if that starts to go, I might mute myself real quick during this introduction, so bear with me. Thank you for attending our Telemedicine ECHO. The Heartland Telehealth Resource Center and the Missouri Telehealth Network have partnered together to bring you these ECHOs for providers in Missouri, Kansas, and Oklahoma. And we've addressed topics such as teledentistry and clinical and operations and technology, and we have a lot more to go. So we also would love to hear from you about what you would like to hear from this ECHO. And so if you have some ideas of things that you need to hear, please let us know in the chat and we'll take those into consideration. I'm Janine Gracie, Project Director of the HTRC, and I have the honor to moderate these sessions. Before we get started, I'd like to ask everyone on this ECHO to rename your screen. So I want your first and your last name and the state that you're from so that we can more directly answer your questions appropriately. So if you would just right click on your picture or your name, and you can rename and put your first and last and your state in that. Thank you so much for doing that. That helps us out a lot. Let's see if I have anybody joining by phone. It doesn't look like it. So right now we'll have the Hub team members introduce themselves. Karen, we'll let you go first.
Thank you so much. Karen Edison, Missouri Telehealth Network and Show Me ECHO. Welcome.
Wonderful. Thank you, Karen. Rachel.
Ooh, sorry about that. Can you skip me and I'll come back to me?
Yeah, we'll do that. That's great. All right. So Robert.
Hi, I'm Robert Stiles with the University of Kansas School of Medicine, and I work with the Heartland Telehealth Resource Center here in Kansas.
Thank you, Robert. Tim?
Good morning, Tim Davis, Telehealth Manager from Oklahoma State University in Tulsa, and I work with the HTRC in Oklahoma.
Thank you, Tim. Good to see you. Heather?
Good morning. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS in Tulsa.
Thank you so much, Heather. Now, Rachel.
Sorry about that, everybody. Somebody knocked on the door and my furry friends kind of went crazy. I'm Rachel Mutro with the Missouri Telehealth Network and the Show Me ECHO program, as well as the Heartland Telehealth Resource Center. Happy to be here.
Thank you so much. Usually we have Evelyn Nelson, but I believe she's traveling today, so we wish her good travels. Usually when we get this many participants, we don't introduce, but I think we're probably pretty good to introduce today. So let's take a moment and just have everyone go around and introduce themselves. And so I'll just call out your name and allow you to introduce yourself. So Anne.
Hi, good morning, guys. I'm Anne Simon. I'm a social worker with Mercy Hospital in St. Louis.
Thank you for joining us, Anne. Jackie.
Jackie Griffin at Truman Medical Centers in Kansas City.
Wonderful. Thank you, Jackie. All right. We've got Lauren.
Hi, everyone. Lauren Dahm, Telehealth Coordinator here at the Missouri Telehealth Network.
She's one of our behind-the-scenes workers for ECHO. She does a great job. Trika.
Good morning, everyone. I'm Trika Young. I'm the Outreach Coordinator here at Missouri Telehealth Network.
Thank you. Allison?
Thank you.
Good morning, I'm Allison Troutwine. I also work at Truman Medical Centers with Jackie Griffin in the UMKC Health Sciences District.
Wonderful, thanks for joining. Jerry.
Jerry Wilmus. I'm the Executive and Medical Director for Northwest Missouri State University. I also am affiliated with Mosaic Life Care based out of St. Joseph, Missouri.
Wonderful. Thanks so much. We have Jay Mann. Oh, you're on mute.
Obviously a neophyte, sorry. Josh Mann at the University of Mississippi. I'm the chair in preventive medicine there, and I'm going to work on renaming myself here in a second.
Great, thanks, Josh.
Thank you.
Felicia.
Hi, I'm Felicia Richards. I work at your Community Health Center, which is a federally qualified health center in Rolla, Missouri.
Thank you for joining us. Shelley Cooper.
Hi, I'm Dr. Shelley Cooper from Kansas City, Diversity Telehealth. I work with underserved populations and bring telehealth into underserved areas.
Thank you, Shelley. Junie.
Hi, my name is Junie Langham. I work in at Baylor College of Medicine in Houston. I'm still trying to stay connected to my people at Mizzou. So Dr. Edison and Richelle Marting invited me to join this group, and so I continue to cling on.
Well, we are so glad that you have. Thank you for joining us. Kelly.
Hi, my name is Kelly Shuck. I am the Behavioral Health Director at Family Health Center in Columbia, Missouri.
Wonderful. Thanks for joining. Grace.
Hi, my name is Grace. I'm a pharmacy student at University of Missouri, Kansas City.
Wonderful. Love to have students on board. Chris. Well, Chris must be busy. We'll come back. Helen. Oh, on mute.
Okay. I am a physician and I volunteer at the free clinic in St. Joseph, Missouri.
Wonderful. Thanks for joining us, Helen. My mother's name was Helen, so I love that name. Christina. Oh, you don't have a microphone. I apologize, but she's Director of Student Health Services at Central Methodist University in Fayette, Missouri. So thanks for joining us. And we'll go back to Chris. Chris has joined us before, so Chris Ellis. So thanks for joining us, Chris. Angie?
Missouri.
Oh, could you say that one more time, Angie?
Hi, I am Angie Johnson from GLO and Associates. We are a pharmacist consulting group out of Jefferson City, Missouri.
Oh, wonderful. Thank you, Angie. Milmari?
I'm Mila Marie Cunningham, a retired physician from Columbia, Missouri, interested in the concept.
Oh, thank you so much for joining. And sorry, I butchered that first name.
That's okay.
It sounds so much better when you say it. Mila Marie, that's beautiful. All right, Daniel.
Sorry, I got on late. Daniel Gillen, Swope Health Services.
Wonderful. Thanks for joining us, Daniel. And Candace Shaw is from Oklahoma, and she used to be associated with the HTRC, but it looks like she's on the phone. So we'll let her do that, and then we will get started. So thank you for taking the time to do that. I'm going to go through these announcements fairly quickly so that we can get started, because I know that you're all anxious for today's presenter. So for a more interconnected environment, we use first names only on our Project Echo. That's something that we practice with any Project Echo that we do. If you do ask questions, please be conscious of confidential or protected health information. If you have a question during our presenters' didactic, please use the Ask Joe Kingsbury. And you get to that by going down to the 2 in chat. So it's, you know, usually to everyone, that type of thing. And so then you'll scroll down and ask Joe Kingsbury and put your question in there. Now, if you're not shy, you can always ask the question, you know, after the didactic, and you can do that face-to-face if you desire to do that. If you desire to speak, please raise your hand and you'll be recognized. Keep your microphone on mute until you're ready to speak. We all know the disasters that have happened during COVID with those kinds of things. And introduce yourself again before you ask your question, and maybe the state that you're from, just so that we know and we would be able to coordinate that better. The presentation and any case studies that we have is available on Box. If you have trouble getting to Box or figuring that out, Lauren is happy to help navigate that. I know that there's been a couple of people that have had some difficulty. So just let us know. By all means, we want you to have this material. And the value of ECHO is in the case studies. So if you have a case study you want to present for our Telemed Project ECHO, please do not hesitate to do that. So our didactic today is Richelle Marting. She is a JD, assistant professor at KU Med, and her teaching interests include healthcare law and governance, healthcare environment, or healthcare reimbursement, sorry, and privacy and security. So all of those things that are the necessary musts that sometimes get shoved aside when we're trying to work and get our telemedicine technology going. And so she's going to let us know what we can do better during COVID-19 with the billing prospects. So Richelle, I am going to let you take it away.
All right, great, thank you. Make sure my microphone's working. Can you hear me okay? Perfect, okay. Well, even probably more relevant than being an attorney, I'm also a registered health information administrator and a certified coder. And that's how I started my career. And then the legal thing kind of came later. So my background is in medical record documentation, and kind of went through that education at a really critical, really great time when everybody was transitioning from paper to electronic medical records. So some of my first experiences were literally taking paper medical records into the electronic setting and understanding how we were going to document services, and then using the coding background to translate that into the billing codes and understand how we're going to get paid for those. So let me share my screen here. Make sure y'all can see that presentation okay. And what I'm going to spend some time talking about this morning is how you get paid for some of these telemedicine and telehealth services that you're working on providing. I'll jump right into this here. And let me go back, sorry, jumped ahead. We're gonna go to telemedicine and start here. When I use the term telemedicine, I'm kind of using this as an umbrella term for anything that is not your typical in-person face-to-face service. And that's important because if you were to go out and Google billing for telemedicine services, you're going to see the term telemedicine, telehealth, there's all different kinds of terms, but some of those terms are very particular terms of art from a coding and billing and payment perspective. So I'm kind of using this in sort of the layman's sense of a very broad term to cover telehealth, which is a technical term of art under the Medicare program and has a really specific meaning in how you code and bill and get paid. Other communication services, so email type visits, patient portal communications, phone visits, I'll go through some others. A relatively new concept that's a non-face-to-face service called remote patient monitoring, where you can have the patient record things like their vital signs, their activity levels. So it's not a face-to-face service, but that data can get transmitted to healthcare providers and can be coded and billed and oftentimes paid. I'm going to put an asterisk at the bottom here because there are so many more non-face-to-face services that you could get paid for that are, I think, fall under this category of telemedicine, like monitoring patients' chronic conditions, transitioning them from a hospital to another setting. We could spend a whole day, I could spend a whole week probably talking about all the different possibilities and how to code and document and bill for those, but I'll focus on some of these initially. For telemedicine is kind of a broad topic. We also have to kind of break it down to a normal environment and a COVID environment, because our coding and billing rules are very different in those two scenarios. And we've got lots of exceptions and lots of waivers and flexibilities right now. So just to kind of keep in mind of all the topics, all the services that I'm talking about, from a billing perspective, there are some things that we can do when those get reported to insurance companies right now during the COVID emergency. One of those is there is a modifier. So a modifier is just a little 2-digit alphanumeric code that's going to get displayed on the claim form, and it tells the payer something about the service that has been provided. And there's a modifier that was created during COVID called CS, and I think of it as cost sharing. I don't know if that's actually what it stands for, but this modifier tells the payer and Medicare in particular that the service, the telemedicine service, is related to COVID, assessing symptoms or diagnosis or testing services. And when that modifier is added to the claim that you're billing, the cost sharing is waived. So this can be a great advantage to your patients because their deductible is waived, coinsurance and copayments are waived when that modifier is reported to Medicare. And a lot of the commercial payers are following suit and taking advantage of that modifier as well. There's some criteria for that. It started on March 18th and it's going to continue through the end of the public health emergency, and that's the federal public health emergency. So as long as that is still active, this modifier can be used to waive patient cost sharing. And the service has to be related to COVID in order to waive the cost sharing, not in order to provide the service. There are also modifiers that we can add to claims for telemedicine services right now during the COVID emergency. One of those is a CR modifier for catastrophe and disaster related services, or a disaster related services. Which modifier you use kind of depends on what provider type you are and the type of service. And what these are designed to do is indicate to Medicare that the service you're being provided is provided under a waiver. So in a non-COVID environment, you would not have been able to provide the service or provide it in that particular way. And by adding that modifier, you're explaining, I'm relying on a waiver to deliver this service. So in the telemedicine context, an example of a waiver that you might be relying on is at the federal level. We had some waivers early on that would allow providers to see patients in states where they may not have a license and could bill Medicare for that service. So that would be a federal waiver that if you have provided the service in that way, you may want to add a modifier to communicate that. I'll put an asterisk on that, lots of asterisks, because we could certainly dive so much deeper into this. That is a federal waiver, but it doesn't necessarily waive the licensing requirements at a state level. And so that would kind of be another layer to the onion there. So let's go into the 3 different types of telehealth, telemedicine services that I wanted to go through this morning. Telehealth is kind of a term of art that Medicare uses, and it's a benefit under the Medicare program with a lot of really specific requirements in order to bill and be paid for these services. You've probably gone through some of these in different sessions, but to give you kind of a big picture overview, there are requirements or restrictions on where the patient is located, both geographically in a rural area and physically where they're located in terms of a healthcare setting, like a physician office or a hospital. Some of those requirements are waived right now during the COVID emergency. So if you go back a couple of items and look at the catastrophe related modifier, if you are providing a service because the patient is located at home, which is not normally a setting where you could see a patient via telehealth, but we can, during COVID, we may need to add different billing modifiers to the claim to indicate that. Medicare doesn't pay for everything provided via telehealth. There is a published list of services and associated billing codes that gets updated every year. That list still stands, but has been significantly expanded for the duration of the public health emergency in terms of what we can provide via telehealth. In terms of billing for telehealth services, there are different modifiers that you can use depending on your provider type. If you're a critical access hospital and you use method 2 billing, there are certain modifiers that you have to add when providing telehealth services. And rural health clinics, FQHCs, when providing telehealth services, CMS has some instructions on exactly which form and exactly which field you are to report the costs that you incur for providing your telehealth services on your cost reports to Medicare. And under the Medicare program, these telehealth services are broken out into 2 components, or 2 different fees. And one of them is a fee or a payment for the location where the patient is, and that's the originating site. One of them is a fee for where the provider is, the distance site, which is kind of like your professional fee for the service. So when we look at the originating site fee, this is designed to give you a little bit of compensation for those overhead costs that you incur. You have to schedule the patient, to bring the patient in, to have someone room the patient and get them set up for a telehealth service. It's a flat fee. It's not adjusted geographically, so it's the same rate across the entire country. This year, it's about $26 for this payment. And the billing code, the service, is Q3014. The diagnosis codes that you would report in order to get paid for this originating site fee aren't limited, so it's whatever the reason, the patient's conditions or their reasons for visits. One kind of caveat to keep in mind is that if a service would not be covered by Medicare face-to-face, like a well woman exam or a well male exam, it's also not going to be covered if you provide it via telehealth. So from a diagnosis code perspective, if you bill the originating site fee and you have a diagnosis code that describes a routine preventive encounter for a well woman exam or a well male exam, the originating site fee is not going to get paid, just like you wouldn't get paid for that service if it was being done face-to-face. There is cost sharing for both the originating site fee where the patient's located and for the distant site, the professional fee that's being reported. So the typical cost sharing for Medicare applies. However, during COVID, if it is related to symptom assessment or anything COVID related in terms of diagnosis or treatment, you can add a modifier, CS, to the billing code Q3014, and that will waive that cost sharing for the patient only for the duration of the COVID emergency. And then once that emergency is over, cost sharing would continue to apply for all of these services. Let's see, the eligible originating sites have expanded from what is ordinarily allowed during the scope of the emergency. And one frequently asked question I get about both the originating site fee and the distant site fee is, can we waive the cost sharing for the patient? So if it's not a COVID related service and the patient has a 20% coinsurance, can we just not collect that from the patient when we're providing a service via telehealth? In a normal environment, there are risks to waiving cost sharing under federal and state anti-kickback laws. However, I've got the link down here, item number 2, during the COVID emergency, the Office of Inspector General that would typically investigate and enforce kickback type issues has said we will not pursue enforcement if you are waiving cost sharing for telehealth services during the public health emergency. So the second part of a telehealth service, these services under Medicare, is the distant site, which is your professional fee for providing the service. Typically, only certain practitioners are allowed to bill Medicare for a telehealth service. That list has been expanded during the COVID health emergency. So any practitioner who is enrolled with Medicare and allowed to bill Medicare for services during the COVID emergency can provide telehealth services as well. And that was a fairly late development in our waiver process with Medicare. So for example, physical therapists, speech therapists, and occupational therapists typically cannot provide services via telehealth. And right now during COVID, they can. So when you're billing for this professional fee, there are, if you've ever looked at a claim form, there's like 100 different fields that you have to get just right to get paid correctly. So I wanted to walk through a couple of those fields where there are some billing nuances. And this can vary drastically depending on whether you are a professional billing for professional services, a critical access hospital, rural health clinic, FQHC, but these are some of the highlights on the billing and claim forms. When you are when you're choosing a code to describe your service, generally choose the code that would describe the service if you are providing it face-to-face. So if that's an office visit, you would report an office visit code. If that's an emergency department visit, you would choose an emergency department code. Asterisk, if you are a rural health clinic, there's a specific billing code that CMS has instructed you to use, G2025. And there's an associated revenue code that's going to go with that on your claim, and you'll get paid about $92. That rate, if we are still in a COVID emergency January 1 of next year, that rate's going to get adjusted. It goes up each year. If you're an FQHC, you get 3 codes that you get to report, but you still get the same $92 payment. So we're just going to make the billing process a little bit more complicated. You choose one of the FQHC codes, either G0466, G0467, 68, 69, 470. One of those codes that's describing your the type of telemedicine service. You then also report the code that describes the service if it were provided face-to-face. So an office visit code, an emergency department code, critical care codes, etc. And you add the same G2025 that a rural health clinic's going to report. And if you're an FQHC, that's how you can get your $92 payment during COVID for telehealth services. The list of services that are eligible to be provided via telehealth is updated every year by CMS, and we've got a special list right now for the expanded types of telehealth services that Medicare is allowing during COVID, above and beyond what they ordinarily allow. So that's updated every year. In a normal environment, there's a single code that tells us the place of service. So we have to describe if a service is in a hospital, hospital inpatient, hospital outpatient, physician office. When it's telehealth, it's typically a place of service 02. And what that place of service does is tell Medicare the rate to apply to the telehealth service. During COVID, that has changed. And instead of place of service 02, we use a place of service to describe how we would have billed for it if it was face-to-face. So an office place of service, emergency department, hospital inpatient, hospital outpatient. So that's a change we've kind of got to adjust to right now. In terms of modifiers on the claim, we typically don't have any special modifiers that you have to add to a telehealth service because we're often reporting place of service 02, and that is the way that we communicate that this has been a telehealth service. But during COVID, since we're no longer using a telehealth place of service, we have to add some modifiers to indicate that this was a telehealth service. So during COVID, we're adding a modifier 95 to billing codes that have been provided via telehealth. You may be adding a modifier CS to waive the cost sharing if the service is COVID related. You may be adding a modifier CR if you're providing the service depending on, reliant upon a federal waiver to render that service. And if you're an RHC or FQHC, you may be adding a modifier CG to represent that this is a telehealth service. and that's just for the course of the COVID emergency. In terms of diagnosis codes, again, any covered diagnosis code can be reported for a telehealth service, just like if it's provided face-to-face with the patient. Under the COVID environment, certain diagnoses are more indicative of a COVID-related service where cost sharing can be waived. In terms of what's covered, I've just added a link here if you want to check out the different services that during the COVID emergency are allowed to be provided and paid as a telehealth service throughout the course of the public health emergency. Some of the diagnosis codes that can indicate that this is a COVID-related service where cost sharing can be waived. There are some new diagnosis codes created just in the last couple of months specific to our coding scenarios. So a patient who's been concerned about exposure, there's a diagnosis code for that. If we've confirmed that there was COVID exposure, there's a diagnosis code for that. Once we have a confirmed diagnosis of COVID-19, there's a new specific diagnosis code for confirmed cases. Outside of that, if the patient's just having signs and symptoms that we're assessing, then just like in any other situation, we can assign diagnosis codes that describe those symptoms. Okay, so let's take a look at some of the services that are also provided virtually and remotely, but they're not telehealth services in terms of that very particular definition under the Medicare program. What that means in terms of coding and billing is that restrictions on where the patient's located don't apply. Being in a rural area in a normal environment don't apply. And so there are, in some ways, less restrictions on some of these codes than traditional telehealth under the Medicare program. And these can be e-visits, phone visits. These can be something called communication technology-based services. And so those are things like a virtual check-in with a patient to determine whether that patient needs to come into the office or come into a setting, or looking at a photo or looking at a video from a patient and providing recommendations are additional services that can be separately paid. Just like all of the other telehealth services during COVID, if these telecommunication services relate to COVID diagnosis or testing, we can add a modifier to waive the patient's cost sharing as well. So e-visits are patient initiated, typically, meaning the patient's going into like a patient portal and they're sending a message to their healthcare provider. CMS has an FAQ document that came out late May, I think May 27th, that explained what it means to be patient initiated. So the idea is that they don't want healthcare providers reaching out to patients and then billing for the service. I mean, this really is like the patient calling in to schedule, the patient reaching out with a problem or question or complaint. But that doesn't prevent you from educating the patients about the availability of these e-visits and letting them know where to go to direct their question to initiate these services. An e-visit is asynchronous, so it's not necessarily happening live and in real time with the patient. So think of it as a message thread, an email communication type thread where you're going back and forth. Typically, these are only provided to established patients, although currently there is a waiver of that requirement and you can provide an e-visit to either a new or established patient and still potentially be paid for the service. These are time-based services, so in terms of your documentation in the medical record, you need to record how much time you spent back and forth with these messages to be able to support the code that you end up billing for the service. And it's cumulative, meaning you add the time over a period of 7 days, and that's the amount of time that you would report. So there are a couple of different options in terms of billing, and the codes that you would select depend upon who's providing the service. So the abbreviation QHP stands for a qualified healthcare professional. That term means a healthcare practitioner who is eligible to bill Medicare for services. So physicians, physician assistants, nurse practitioners, they are qualified healthcare professionals. When those are the individuals who are looking at these communications with the patients, responding to them, and we're keeping track of that time to bill, then there are a series of a few codes 99421 through 423, and the only difference in those codes is how much time you've spent over the 7-day period. And the payment is anywhere from $15 to $50 depending on which code you use. If you're an RHC or an FQHC, the code is G0071, and this is temporarily allowed outside of your normal all-inclusive rate during the COVID emergency and allowed as a separate payment. If the individual providing this e-visit and communicating with the patient is not a qualified healthcare professional, not someone who can bill Medicare on their own, but maybe it's a registered nurse, for example. If clinical staff are providing the service, there's a similar bundle of codes that can be reported, and you see the payments a little bit less because they're not physicians or nurse practitioners. But for Medicare, there's a group of codes, and for non-Medicare payers, there's a different group of codes to describe the exact same service. And you can still get paid for those even in the course of the COVID emergency. So let's look at phone visits. So typically, your normal telehealth visit is going to be audio-visual, right? Some patients may not have the internet access or a smartphone with audiovisual capabilities. And typically Medicare doesn't pay for a phone call with a patient. But right now during the COVID emergency, Medicare will pay for phone visits, and there are unique billing codes for phone visits. Just like an e-visit, these are time-based codes. So you're going to select the billing code based on the duration of time that you spend with the patient. And you can get paid anywhere from $46 to $110 when it's a qualified healthcare professional on the phone with the patient. So again, that's a doctor, physician assistant, nurse practitioner. Even though you're on the phone with the patient, you describe the place of service the same way as if it was being done face-to-face. So had that visit, had the patient been available, if they would have been in the office setting, if you were face-to-face, that's the place of service that you would report on the claim. There are also options if it's clinical staff, like a registered nurse, who's on the phone with the patient and talking with them. They're still time-based codes, so you always want to document the duration of time whenever you're reporting a time-based code to justify the billing code that you've selected. These are not telehealth services in terms of how that term telehealth under Medicare. And you can still get paid for clinical staff talking on the phone with the patient, anywhere from $13 to $40. So other communication technology-based services that you can be paid for, even by Medicare, is a remote evaluation of patient images and videos. So I think of this, I've got friends who are healthcare providers, and you're always like, hey, look at my kid's rash, or what do you think of this cut? Is it gonna need stitches? Things like that. That's exactly what this remote evaluation of patient images is designed to do. You could save office time, save time on your schedule, and you could still bill for looking at the images, looking at the video, and providing recommendations to the patient, like, oh, you need a steroid cream, I can send in a script, or patient needs to go to the emergency department. It's a nominal amount, it's about $12, but it's something, right, to compensate you for your time to look at that. There's another one called a virtual check-in, and a virtual check-in allows you to have a phone call with the patient, kind of hear their signs, their symptoms, and their problems, and determine if they need to have a more extensive office visit or evaluation and management service. And as long as this check-in isn't 7 days after a previous visit and doesn't lead to the patient coming into the office, you could bill for that and receive some nominal reimbursement of about $14 per instance. So the last category that I wanted to talk about this morning is it's not a new billing concept, but it is newly payable by Medicare in terms of some new billing codes that came out just a year or so ago. And remote patient monitoring or remote physiologic monitoring allows the patient to have a device that's taking measurements of blood pressure or glucose or weight, pulse ox, etc. And that device is transmitting information to the provider. And when you review that information, you can be compensated for your time for looking at the patient's physiologic data. The codes that you report for remote patient monitoring vary depending on whether the device that the patient's using is FDA approved, and they vary depending on who is performing the monitoring, whether it's a qualified healthcare professional or whether it's clinical staff. And it also varies depending on who's taking the measurements, the patient or the provider. So the largest category of remote patient monitoring is a series of new codes that there's kind of several phases to this. One code describes giving the patient the equipment, getting them set up on the app or the technology that allows that equipment to communicate the data back to the healthcare provider. And there's a code for that initial visit. There's a code for the first month of monitoring, and as long as you spend 16 days of monitoring patient data, you can report that code. And then if the patient's continuing to monitor their physiologic data, you can bill for the service every month, representing the amount of time that you're spending reviewing all that data that's coming in, checking in with the patient on how they're complying with their medications and their treatment or making adjustments and so on. The good thing about the remote patient monitoring codes is they're time-based. You have to spend about 20 minutes per month to build a monthly code, but that can include clinical staff time. So you can be utilizing a registered nurse to look at all of this data coming in and to make sure the patient's complying with their treatment plan, making sure the patient's taking their blood pressure daily or in accordance with their treatment plan, and be paid for that. There are also billing codes that the payment's quite a bit less, but if the patient is self-measuring their blood pressure at home and reporting that data to a healthcare provider, there are codes for that are payable for anywhere from $10 to $14 for those measurements. There are a lot of other options. If you've got patients that are monitoring data and sharing data with you, there's probably a code for it, and there's probably a way to be paid for it if you're doing it appropriately. So glucose monitoring, ambulatory blood pressure monitoring are some other examples of that. So that is just in a nutshell, just scratching the surface. Some of the ideas on how telehealth or other telemedicine type services can be provided now during the COVID emergency, and how our billing right now is a little bit different than outside of the COVID environment. But hopefully that gives you an idea of some of the things that you're either already doing or that maybe you could do in practices and get paid for them, where I think a lot of providers are rendering these services and just not billing or getting paid.
Thank you so much, Richelle. That was a lot of information in a short amount of time. I know that was probably a record for you.
I could easily make this an 8-hour workshop session. Yes.
Absolutely, and some of us need that. I think we'll go to just straight to questions now.
Sure,
Joe,
sure.
I'm going to let you take that away.
Well, thank you, Janine. I'm flattered. So first question we have up is on the waiver for licensure in treating out-of-state patients where you do not have a license, are you also restricted to those insurance payers that you have contracts with?
Okay, so good question. That federal waiver is a waiver that would allow you to be paid for services under Medicare, Medicaid, TRICARE, and I think the Children's Health Insurance Program. So it was, I think, widely misinterpreted when it first came out. It is not a blanket waiver that allows you to see patients anywhere. It is only an exception to the normal Medicare rules that would require you be licensed in the state where the patient's located in order to be paid for a telehealth service. What it does not do is grant any exceptions under those states' professional licensing rules. Many of the states have granted those exceptions for the duration of the COVID emergency. So it's a really challenging time right now if you're seeing patients in different states, because each state has handled that a little bit differently. Some of the states, the governor had a blanket waiver. In some states, the governor gave the authority to the licensing boards to grant that waiver. So the effective date in your state, or the states where the patient's located, when providers could see patients via telehealth in states where the provider doesn't have a license, might differ state to state and is probably different than the federal Medicare waiver. In terms of the commercial payers and the non-Medicare, non-government programs, and when they'll pay for services when a patient's located in a state that you don't have a license in, they are typically going to defer to whatever the state law is. So we're not going to be looking at that federal Medicare waiver. You'd have to know in those particular states where the patient was located, what was the effective date that you were allowed to see patients in those states, and then that's the date that the commercial payers are typically deferring to. Long-winded answer to say it varies. It's going to vary state to state.
Thank you. Next question for you. For organizations where operational practice is not to bill amounts less than $20 to $25, where it's more expensive to process that amount you would collect, is it okay to apply that to Medicare, where cost share is expected at the 80-20 rule, when the patient's 20% is below the collection threshold?
Okay, so another good question, and it's one that I get all the time, even outside of the COVID environment. Within the COVID environment, right now, we have an OIG waiver, and I'd encourage you, there's a link on the portion of the slide where I talked about that shows you the scope of what the OIG is specifically waiving. And in a non-COVID environment, anytime you're waiving cost-sharing amounts for a state or federal program, anti-kickback rules can be triggered. So the concern is waiving cost-sharing for patients might be seen as an inducement to get them to purchase other healthcare services from you that can be paid by federal and state programs. The OIG waiver during COVID says we're going to use our discretion to not enforce or impose any anti-kickback type penalties whenever you are waiving cost sharing for patients during the COVID emergency. The OIG is a federal agency. Most states also have anti-kickback statutes. So the OIG's waiver does not necessarily waive any state laws or kickback requirements. And so you would then have to go to your state's waivers and see if they've waived any requirements under your state laws.
Thank you.
Yeah, clear as mud, right?
So we've got one more question for you.
Okay.
With remote monitoring, where a clinic gives a patient a device to track with at home with intention to return the device within a certain timeline, what are typical processes to charge for the device or create accountability if patient does not return the device?
Yeah, so that's another good question. In the series of remote patient monitoring codes, there is a code for the provision of the device to the patient, getting them set up in the initial education. That code is designed to cover the cost of the device. I'm very aware from talking with providers that it does not always cover your cost for the device, but that was kind of the idea or the intent behind it. So when you report that code to get the patient set up on the device, that's what is that reimbursement that you're getting could provide some compensation in the event the patient doesn't actually return it when they're supposed to. And then you're getting the service, the billing every month when you're monitoring the patient with that device. If the patient does bring the device back in, one thing to keep in mind too, because those devices may be storing and transmitting the information, may have kind of a hard drive on them, so to speak, you've got to have a process to clean and wipe the device when it does come back to you before you issue it to another patient. But if they do bring the device back and you clean it, you wipe it appropriately and issue it to another patient, That second patient can also be billed for the setup, the provision, the education of the device and the equipment. Did that answer the question?
I believe so.
Okay, perfect.
Thank you. Any other questions from the participants? Oh, Joe, you're on mute if you have another question.
Sorry. Yes, we do have another one that came in. How would QHP or clinical staff, such as registered respiratory therapists, seek reimbursement for telehealth asthma checkups in the home environment?
Okay, so say the question one more time for me.
Sure. How would QHP or clinical staff, such as registered respiratory therapists, seek reimbursement for telehealth asthma checkups in the home environment?
Asthma checkups in the home environment. Okay. There are a lot of different options. There are evaluation and management codes that describe home visits when you're going out to the patient in the home that don't necessarily have to be a patient confined to the home, like home health care. There are also codes that you can account for the location of the patient in the home by reporting home as the place of service with the billing code that you're reporting. Typically, if you've got someone like a respiratory therapist, if they ordinarily are not billing for services independently, they're typically billing under the name of the provider who is initiating the service or supervising the service. So that might be a physician or a nurse practitioner. And there are billing rules called incident to billing rules that have to be met in order for that to happen. And fortunately, some of those billing rules have been relaxed during COVID. So some of those no longer require an initiating visit by a physician or a nurse practitioner to order the service. And typically when that has to be provided in the office setting under the direct supervision of a physician or nurse practitioner, that requirement is waived to allow for more general supervision, meaning the billing provider and the respiratory therapist don't have to be physically located in the same location because the respiratory therapist is going out to the patient's home. It doesn't make sense to have the doctor or the nurse practitioner go with them. Where that is a face-to-face visit, I'm trying to think, I don't know the actual code off the top of my head, but it is an evaluation and management code under the category of a home visit that I think would be reported. And then you would have to verify whether that's going to get reported under the RT name and number, if that is a professional that's enrolled with and eligible to bill Medicare independently, or if it has to be billed incident to the services of a physician or nurse practitioner. But where you're actually going to the patient's home, it's not going to be treated from a billing and payment perspective as a telehealth visit. It's going to be treated the same way as any other face-to-face professional service.
Very good, thank you. Any other questions?
We have one more that just came in. On your slide about virtual check-ins and remote evals, you had an acronym CTBS. What does that stand for?
Communication, good question, communication technology-based services. So that is a term of art under Medicare, just like telehealth is kind of an umbrella term under Medicare to encompass a lot of different services that ordinarily would be provided face-to-face that are being done via audio-visual technologies. So that's kind of the term telehealth. Medicare has created this term called CTBS, Communication Technology-Based Services, and they're starting to create and add different types of services under that category. And that abbreviation is used to distinguish them from telehealth because the requirements that the patient is located in a rural area, in certain healthcare provider locations do not apply to CTBS services. And Joe, I'm just looking at in the chat, I see Candace's question, and now that I reread it, I'm not sure I answered it specifically. When she asked on the waiver for licensure and treating patients out of the state when you don't have a license, Are you restricted to those insurance payers that you have contracts with? And the answer is no. You can bill out of network insurance companies just like you would in a normal face-to-face environment. Whether they are going to be obligated to pay for a telehealth service in the manner that you've provided it, you just won't have a contract to dictate the payment rates and the terms of that telehealth service.
Very good. All right.
Janine, we've got one clarifying follow-up question.
Sure.
With regard to the question about asthma checks at home that we talked about earlier. So the checkup visit is broadcast from the patient's home to the provider. The provider is not at home. Does this change the process or codes?
Got it. Okay, so the patient is at home and we are doing a virtual type of check-in, audio visual with the patient located in the patient's home by a respiratory therapist. Perfect, got it. So the way Medicare has broadened the telehealth requirements is that if your RT is someone who is enrolled with Medicare and eligible to bill Medicare services independently, the respiratory therapist can, during the COVID emergency, provide telehealth services and bill for it just like any healthcare provider would. So you would choose a procedure code that describes that service if it were provided face-to-face, like an office visit code, emergency department visit code, hospital outpatient service, whatever would describe that service face-to-face, and even in the level and complexity of the service. If it's related, if it's just asthma and not COVID related, the patient's cost sharing is going to apply. You'll report the place of service if that service were provided face-to-face. So it's not going to be the patient's home, it would be the office setting or the hospital outpatient department setting when you're reporting that service.
Very good. Thank you for that clarification. That's good. Thank you.
We have another question, Janine.
Okay.
They're rolling in.
Yes, that's fine.
Got
a few minutes.
Question. What type of asthma service is allowable and funded by Missouri Medicaid under the primary care health homes?
Oh, good question. I would have to go to, I'd have to go to their manual to look if they have, under the Medicaid program, sometimes they have created unique HCPCS billing codes when it's being done under primary health, under the primary health care program. So I don't know the code to that off the top of my head. I can certainly look at that and send it back that we can send out to the group.
That would be great. We would appreciate that. Thank you so much.